Good evening, everybody. So, again, a controversial topic, cataract with CSR, what to do. Yes. So, central CSCR, fourth common cause of retinopathy. After AMD, diabetic retinopathy, and branch retinal vein occlusion. Typically occurs in males between 20 to 50. No underlying pathophysiologic mechanism till date have been proven. It's thought to be to occur due to hyperpermeable choriocapillaries with RPE dysfunction. Recurrence rate is 31% and first recognized by von Graffe. The etiology, exact mechanism though unknown, but many associations found. Steroids, both endogenous and exogenous. This is the strongest known association. Type A personality, release of glucocorticoids during stress, increase in choroidal vascular permeability, which leads to microrips in RP, H. pylori infection, MDMA or ecstasy, along with sildenafil topiramate drugs, sorafenib and vemurafenib, the anti-cancer drugs. These are all associated and reported with CSCR, and increased sympathetic activity along with obstructive sleep apnea. These are the associations we found in literatures. Common risk factors: pregnancy, alcohol use, untreated hypertension, obstructive sleep apnea, depression, Cushing syndrome, SLE, organ transplantation, end-stage renal disease. So these are all common risk factors. In one study by Sai et al., published in 2013, there is male preponderance between the age group of 35 to 54 years. But in between 55 to 59 years, there is a second peak of CSR, which shows that there is male-female equal, 0.21% and 0.2%. After photorefractive keratectomy and LASIK, there is a report that few cases of CSR after 4,800 consecutive LASIK and PRK cases. This might be due to extensive topical corticosteroid use, elevated cortisol level from stress of surgery, mechanical disturbances after excimer laser, LASIK fabrication in susceptible patients. There is another report in IGO that acute central SerousChorioretinopathy following subconjunctival triamcinolone acetonide injection, less drop approach. So in this series, there are 3 cases of CSCR noted, 0.26% out of 1129 eyes. All 3 patients shows pachychoroid features on enhanced EDI-OCT. So preoperative EDI-OCT might help in identifying these patients who are prone for developing CSCR. So keeping these things in mind, we have 2 questions. What to do in this macular problem if associated with cataract? So if the patient presents with cataract and has a past history of CSCR, question 2, if the patient presents with cataract and has a neurosensory detachment at presentation. So I have found one article. This is published in Korean Journal of Ophthalmology in 2021 June. So this is a small group of patient retrospective study. This shows the short-term outcomes of cataract surgery in patients with a history of central serous chorioretinopathy. This study shows that significant improvement in visual acuity was noted after uncomplicated cataract surgery in eyes with history of idiopathic CSCR, regardless the presence of SRF. A definite increase in retinal thickness or recurrence of CSCR noted in only a limited proportion of patients. Further studies are required to identify whether the cataract surgery has a long-term influence on the clinical course of CSCR. Keeping this paper in mind, I think we can answer the questions. If a patient presented with significant cataract and has a past history of CSCR, no NSD, neurosensory detachment found in the pre-op OCT, cataract hinders the vision in case of old CSR, cataract surgery after proper counseling. Proper counseling means that there is chance of recurrence. If possible, in pre-op EDI OCT, if we can see that there is a pachychoroid, then we can also explain the patient that, see, you have cataract, but you have a chance of recurrent CSR. And post-op topical steroid for 45 days didn't show any significant recurrence of neurosensory detachment by this study. Question number 2, if a patient presented with cataract and has CSCR at presentation, significant amount of cataract with neurosensory detachment, FFA not possible, EDI OCT possible, then we have to go for EDI OCT, and cataract surgery after proper counseling with minimum post-op steroid. Pre-op FFA possible, shows leakage, treat the leakage, wait for NSD to resolve, and go for cataract surgery after proper counseling that there is chance of recurrence. Pre-op EDI OCT, suggestive of pachychoroid vasculopathy, then treat accordingly, and pre-op steroid for 45 days didn't show any significant recurrence of neurosensory detachment. So these are all about patients. What about surgeons? So there is one study which shows that the ophthalmic surgeon, this is published by Ahmad M. Mansoor, that CSR of the left eye at initial visit, follow-up OCT scan, 5-6 years OCT scan, serials OCT scans are there. And these are the conclusions, that resolution of CSR after 3 to 4 weeks of occurrence, but the recurrence induced by stress in the operating room. The available evidence suggests that those overcommitted surgeons, type A personality, may very well be most susceptible to burnout and central SerousChorioretinopathy. So please, thank you. Nothing more